Next, we have Dr. Gandhi. Dr. Gandhi grew up in Memphis, Tennessee, and he's lived in Virginia since 2015. He studied at the prestigious Brady Urological Institute at Johns Hopkins Hospital, and now he's here to speak with us. He also is a physician at Nova Alexandria Hospital. So please give it up for Dr. Gandhi.
Well, thank you very much. Thank you to the Congressional Caucus, the Men's Health Network, and Zero, the End of Prostate Cancer, for having me here. Thank you for your wonderful presentation explaining prostate cancer screening. So, as a urologist, we see a lot of these things, and with 1 in 9 men being diagnosed with prostate cancer, just kind of around this room, there's probably about over 30 to 35 men that you're talking about, 4 men alone in this room being diagnosed with prostate cancer, to kind of make it real. That's what we're looking at. And a lot of times, we were talking about information dissemination, that when the guidelines came out in 2012 as a grade D recommendation, it got a lot of press saying, don't do this, don't do this. But that information, again, how it's disseminated, also what's important is how it's interpreted. And there were a lot of studies that came out that said, from a primary care physician standpoint, they saw that as, oh, we don't have to do PSAs, we don't have to do rectal exams either, we don't have to do anything for prostate cancer screening. And I had a lot of patients who would come and said, oh, my doctor said that's not needed, the guidelines said don't do it. And it was never even mentioned in that. So again, a lot of it's just understanding the information, but also the interpretation. And as Dr. Durant was talking about, having that informed conversation when you have a gentleman who has emphysema, has heart failure, has diabetes, has all these issues that have led patients to have multiple hospital admissions, it's really hard to have a conversation about, well, what's your risks and benefits about PSA screening? And a lot of times I'll see those patients who've come to me and they're like, I don't even know what the PSA test is. What does this mean? And so there are some discrepancies there that, even with guidelines saying you've got to have these conversations, again, it ultimately comes down to then how that guideline is being interpreted and how it's implemented in practice. So those are some of the limitations. I think that it's great when we make these large guidelines say, oh, we all agree that's great, but I think we've kind of heard, on practical standpoints as well, that it's not as easy as just saying this is the guideline and then all of a sudden it just happens. There are a lot of barriers and limitations to it. From a urologist perspective, of course, we were upset when a grade D recommendation came out. In 1987, when the PSA test started, prostate cancer mortality rates were high. And over the subsequent years, we saw a significant drop. Of course, you can't ever attribute everything to just one test. There's, I'm sure, many factors, but that there hadn't been a drop in prostate cancer mortality until we started to see this, that we had to kind of believe PSA was making a difference. So, of course, the American Urologic Association came out with recommendations saying, hey, we don't agree with this grade D, and these are certain recommendations. But what I believe happened is it really opened the eyes to a lot of urologists, mainly regarding overdiagnosis and overtreatment. And I think what we took away from that grade D recommendation was that those were real issues. A lot of men were getting either at health fairs or free prostate cancer screenings, all this. I mean, thousands of men were getting PSA tests who may not have needed it, and then ultimately led to a biopsy and led to treatment for a cancer that may have been a very low-grade cancer that may never have caused an issue. And now this man is battling issues with leakage of urine or issues getting an erection. So there were definitely some issues with overdiagnosis as well as overtreatment, which I believe the guidelines really made us abandon a caveman approach of you're 50, get a PSA, and it really made us smarter to say, okay, well, what is your risk? Should you get a PSA? And also evaluating these individual risk factors, family history, African-American race, as you mentioned with Agent Orange. Certain higher risk categories that we have to, medicine is not a black and white issue to just say, screen everyone, don't screen anyone. And I think that was kind of the objection we had with the grade D recommendation was don't screen anyone. I think this, as a clinician, that's the science of medicine there, is to take a gentleman who's in front of you and assess those risk factors, have these conversations to make a determination that could you benefit from PSA screening or not. And that's That's what shared decision-making is, and that's what you're going to read in their guidelines. You're going to read in the American Urologic Association guide. You're going to see that term, shared decision-making, and that's where I think, talking about what's the value of it, or what's the benefit and things, I think it all kind of ties in to right there, the science of medicine, to have that conversation with somebody. Especially, and you had mentioned men over age of 70. I mean, I see plenty of men, 75, and they're healthier than I am. They're running like a marathon every weekend. I mean, yeah, I'm screening that guy. He's going to live till he's like 150, So, I mean, it's having that conversation versus the guy who's 72 and he's had 3 heart attacks. It's a whole different, aspect, and that's why, again, it's again, the science of interpreting who's in front of you. The ways it made us smarter in terms of overdiagnosis, it used to be get a PSA. That was the best test we had, and now we've got so many newer tests, whether they're blood tests, whether there's urine tests, there's even tissue tests to try and really help identify what your risk status is. And we do a lot of this risk profiling in our practice to say, okay, well, what is your risk of developing prostate cancer based off of not just age, family history, or race, but also based off of these additional parameters outside of PSA. So I think it's led to the development of a lot of these newer tests because we realized that overdiagnosis and overtreatment was a big problem. And in addition, you see a lot with MRIs. We've been doing a lot more with MRIs for the prostate. We've gotten a lot better with that, and that's allowed us to actually do more select targeted prostate biopsies to improve accuracy. There was actually a large New England Journal of Medicine article in March of this year detailing MRI biopsies and showing how it does increase your rate of prostate cancer detection, but of clinically significant cancer, which are more aggressive types of cancer that require treatment. So I feel like we've become smarter in this sense, but again, so much of this is about information dissemination. I know when the guidelines first came out in 2012, Forbes published a large article that said, is President Obama's prostate more important than yours? Because he did get a PSA test at the age of 50. And again, it's how things are conveyed, that's what people will read, and it's not really understanding the whole scope of the information. So as we talked about active surveillance, that's one of the ways to reduce overtreatment. These are men who have low-risk cancer that is actually safe to watch. If you heard, Dr. Chris' information about prostate cancer, these trials were going on for 10 years, 15 years, and that's what the data is because prostate cancer is found. You're going to have a few men who may pass away within a couple years, but overall, it's a slow-growing cancer over 10 or 15 years, and we found it's actually safe to watch some of these men, and the hardest part for me is explaining to somebody that you have cancer, it doesn't need to be treated, and everyone looks at me like I'm crazy, and I mean, you have to understand that the moment someone hears cancer, they stop listening to you. That's the first thing that happens. And they're thinking, what does this mean for my family? When am I going to die? What about my children? And they're thinking all of these other aspects. And so you're trying to explain to them, oh, we're not going to treat your cancer. Don't worry about it. You'll do great. I mean, they're just already in a shock. So it is a hard conversation to have, but we have some of these tests now that will help us. And the data is showing in 2005, 25% of men elected for active surveillance, watching the cancer. And in 2015, that number's up to 75%. So people are becoming more informed. The Washington Post just had a large article on the 15th, a couple days ago, about active surveillance. And so it's getting more mainstream. People, don't look at you as crazy anymore, saying, oh yeah, I understand that, especially with prostate cancer. We can do these things. So, as I was upset with the guideline of a grade D, it really opened our eyes, I think, to overdiagnosis and overtreatment as a larger problem. And I think that really caused a lot of these changes that we're seeing here, that now we're starting newer techniques to treat not the whole prostate for cancer, but certain isolated lesions to try and decrease those rates of these complications that occur. We're doing more targeted biopsies to decrease these rates of potential complications. So I think all of this, has made us smarter, made us better, and we've been able to detect more aggressive cancers that require treatment. But at the end of the day, one of my big things as being a patient advocate for my patients is we've got to increase that awareness. And I think you guys had mentioned that, we see it here. We work with Drew and with Matt regarding Zero, the end of prostate cancer, and these large run walks across the country to try and raise awareness for men. For breast cancer, you'll have 1 million women show up for these events, and they'll talk about it and screening. But it's hard to get men to come to these events because one of the keys are men feel great. They're asymptomatic. They have no symptoms of prostate cancer. And to encourage them to say, you've got to go get checked, go see a doctor. How many here will go see a doctor when they're feeling great? You go when you're sick. And so that's one of the barriers to this. So I think there's a lot of good that comes out of this, especially with the grade D recommendation, and then coming into a grade C saying you've got to have these conversations because, like I said, medicine is not black or white. There's a science to it, and everybody is different to really assess what your individualized risk factors are. And I think that's really what's hammered home with this. Thank you.
Dr.